70-year-old man with abdominal pain. CT scan of the chest, abdomen, and the pelvis showing the right rectus abdominis muscle is expanded with an oval-shaped, high attenuation lesion. So this is the normal rectus abdominis muscle, and here this is the linea alba, this is the linea semilunaris, and the external oblique muscle, the internal oblique, and the transversus abdominis muscle. If you look carefully here, this is the IVC, and this is the right renal vein and the left renal vein. Okay, so below the renal veins, below the level of the renal veins, this part of the IVC is called the infrarenal part. So the infrarenal part of the IVC showing IVC filter, which is in situ. So I have here IVC filter, which is in situ in the infrarenal part of the IVC. There is also several gallbladder stones seen within the collapsed gallbladder. So these are the collapsed gallbladder containing several gallbladder stones. This is the urinary bladder catheter, which is seen in situ within the urinary bladder here. And if you go down, it will be seen within the prostatic urethra. The catheter is seen within. Then if you go down, it will be seen within the membranous urethra. Then within the bulbar urethra. And within the prostatic urethra, within the penile urethra, which is the last part of the urethra. The chest cuts showing bibasal, linear branching opposites, okay, with centrilobular nodules, with adjacent centrilobular nodules, centrilobular nodules, giving the tree-in-bud pattern. Also, as you can see, there is bronchiectasis, okay, bilateral basal bronchiectasis, The interpretation here, the inserted IVC filter indicates that this patient is most likely had previous DVT, deep vein thrombosis, and the inserted device here is most likely a prophylactic therapy to prevent traveling of blood clots from the previous DVT into the heart and into the pulmonary artery. So this device is inserted to prevent pulmonary embolism. And along this device, the patient is most likely on another prophylactic therapy, which is anticoagulant therapy, to prevent future formation of DVT and pulmonary embolism. So this patient is most likely on anticoagulant therapy, and the anticoagulant therapy he is on is most likely has contributed to bleeding within the right rectus sheath. So this high attenuation lesion is most likely to be acute right-sided rectus sheath hematoma. So the diagnosis here is rectus sheath hematoma. However, the lung changes here could be due to pulmonary infection or due to pulmonary hemorrhage, alveolar hemorrhage. Okay, as this patient is on anticoagulant therapy, is most likely to be on anticoagulant therapy, which may contribute into pulmonary or alveolar hemorrhage triggered by coughing. However, pulmonary infection as pulmonary TB should be excluded. Okay, so here this is a differential diagnosis of three-embodied pattern: HEM, pulmonary hemorrhage, pulmonary exudate or emboli, or mucus plugging or malignant cells. The three-embodied pattern is most likely to be due to filling of the small pulmonary airways, okay, the pulmonary bronchioles and alveolar ducts is most likely to be filled with either hemorrhage or exudate, inflammatory exudate, due to pulmonary tuberculosis or sarcoidosis, or filled with tumor emboli due to breast carcinoma or gastric cancer, or filled with mucus plugging due to cystic fibrosis, or malignant cells infiltration from adjacent pulmonary lymphoma or carcinoma. However, pulmonary hemorrhage is the most likely cause of three-embodied opacities in this patient. So the management here, this patient needs more lab investigations. So the lab investigations for his bleeding disorder is coagulation profile. This patient needs coagulation profile. And for the chest infection, for the probability of a chest infection, this patient may need complete blood count. Also, this patient needs to be referred to vascular as well as chest clinic. So this patient needs urgent chest clinic as well as vascular referral. That's it.